So, chronic stable angina, it is a predictable chest pain or discomfort occurring with exertion or emotional stress, relieved by rest, maybe sublingual nitrates within 5 minutes, and no change in pattern over the past 4 to 6 weeks. It is caused by fixed atherosclerotic coronary artery stenosis of more than or equal to 70%. So, clinical features are site onset character, radiation, association, triggers, exacerbating and relieving factors. The character is usually pressure, squeezing, or heaviness, band like, but never positional or sharp. Location at retrosternal and may radiate to left arm, jaw, neck, or epigastrium, and duration is usually less than 20 minutes. More than 20 minutes to 30 minutes is actually the cell injury not sustaining the ischemic insult and leading to infarction, which is then not chronic stable angina, and it is probably unstable angina or non-ST elevation MI then. Precipitation is usually by exercise, cold, heavy meals, and emotional stress. If emotional stress is the cause of exacerbation of chronic stable angina, the severity is more than with the exertion or cold or heavy meals. Atypical forms occur in women, elderly, and diabetics. They may be having dyspnea, fatigue, nausea without classic chest pain or classic chest discomfort. How would you investigate such a case? Troponin is normal in this patient with stable angina, and resting ECG is often normal. It may show LV hypertrophy because of accompanying hypertension, prior Q waves because of old MI, and T wave changes. Fasting lipids, glucose, hemoglobin A1C, complete blood count, and thyroid function tests are required to rule out any primary or secondary causes of hyperlipidemias, any presence of diabetes mellitus and its severity, anemia that increases the severity of angina, and hypothyroidism as well as hyperthyroidism, both interfering with lipid profiles and heart rate and thereby increasing the severity of angina. Exercise ECG is done for first line non-invasive investigation, and it is positive if there is ST change of more than or equal to 1 mm as depression. Stress echo and nuclear perfusion imaging is reserved for those people who are having baseline ECG problems that can lead to misinterpretation or difficult interpretation of ECG during exercise tolerance test. For example, left bundle branch block, WPW, and patient with pacemaker. Coronary CT angiography is a preferred non-invasive anatomical test. It has a high negative predictive value, meaning that it rules out any coronary artery disease if its result is satisfactory and there is no occlusion on CCTA. Invasive coronary angiography is reserved for those patients who are destined for mechanical revascularization either through angioplasty and stenting or through coronary artery bypass grafting. What is the management of these patients? Likely control of risk factors and lifestyle modifications regarding those risks that lead to angina, and also management of the chest pain with medication as beta blockers and long-acting nitrates, calcium channel blockers, especially rate-limiting calcium channel blockers if beta blockers are contraindicated because of active bronchospasm or any other contraindication to beta blockers. that is not contraindicating rate limiting calcium channel blockers. However, if heart rate is the issue and patient is in first degree or advanced second degree heart block, both rate limiting calcium channel blockers and beta blockers can be deferred, and a dihydropyridine calcium channel blocker like amlodipine may be applied if the blood pressure is not low. Long-acting nitrates and ranolazine can be used. Ivermectin is also in the line. Sublingual nitroglycerin is used for acute relief. It is put under the tongue and the patient waits for 5 minutes for taking the relief. Meanwhile, patient may cough slightly during the chest pain episode, and that also reduces the anginal severity. Antiplatelets are usually not needed if there is no previous MI, but if there is previous MI, antiplatelets may be prescribed as well. High intensity statin is usually recommended depending upon the patient tolerating the side effects of statins. Percutaneous intervention are cabbage for significant symptoms that are refractory to medical therapy, or the patient having high risk anatomy, for example, left main stem disease and three vessel disease with reduced EF. In such a situation where there is triple vessel coronary artery disease or left main stem disease, the bypass surgery is a preferable mode of revascularization rather than stenting, and also in diabetics. So there are certain important pearls. Stress testing is first if the pre-test probability is intermediate. Coronary CTA is preferred to low to intermediate probability patients. A positive stress test with ST depression in lead V4 to V6 may suggest left main stem territory ischemia. The left main stem may be involved. LED territory cannot be exactly pinpointed by this diffuse ST depression. It indicates a diffuse disease in three vessels or left main stem. Coronary artery bypass graft is superior to PCI in diabetics with multi-vessel coronary artery disease. There are different classifications for symptom checking. One of them is CCS, Canadian Cardiovascular Society classification, with class 1 strenuous activity causing angina, and class 4 CCS symptoms at rest. Beta blockers are first line. CCBs are used if beta blockers are not usable because they are contraindicated. Troponin is always normal in stable angina, and any deviation will indicate that there is myocardial cell injury, there is membrane rupture, and the management is then changed to acute coronary syndrome. So the patient doesn't remain in stable angina if the troponin become positive. It is basically then acute coronary syndrome.